Good afternoon, friends. David Wright here, and I am your host of the Disruptive Innovators Champions of Digital Business podcast. And today I am lucky enough to be joined by none other than Richard Zane. Richard, pleasure to have you on.
Thanks for having me. Glad to be here.
Yeah, absolutely. So Richard, for any of our listeners who may not be familiar with you, I know you've done a number of these podcasts and things of that nature, but could you just tell everyone a little bit about your current role?
I am currently the Chief Innovation Officer and Chief Medical Officer of UCHealth. UCHealth is a 14 hospital, $9.5 billion system based in Colorado.
Absolutely, very familiar. I've learned a number of innovative things that you guys have done over the years. So excited to get into that today. Richard, I like to start all my episodes though with just if there was one piece of actionable advice you might look to leave everyone with today, what might that be?
Focus on the problem.
Hmm.
Be crystal clear about what your problem statement is. Think less about the technology. Think more about workflows and how people adopt technology and tools, and think very clearly about the problem that you're trying to solve.
Great advice. Seemingly simple, right? But most good ideas are simple. And there's so often that we'll get brought into projects where there's a technology implementation going on. There's been such little thought as to how we're operationalizing that technology to actually solve for a problem. So, um, definitely easier said than done, but profound advice to start us off here. So I appreciate that.
Glad it worked on the first try there.
So Richard, I want to before we get into some of the cool things you guys are doing at UC Health and maybe some of our thoughts on healthcare and where we are today and where we're going. I wanted to just talk a little bit about you as an executive, kind of how you started out, where you began your career, and just learn a little bit more about, how you got to the point that you're at in your life today.
Pretty random, in all candor. I was born in Switzerland. I lived in Italy till I was in second grade, first grade. Moved to New Jersey, where I went to elementary school, middle school, and then outside of Philadelphia, middle school and high school. And I came home one day and told my dad that I wasn't going to go to college, that I wanted to race motocross because I did a lot of motocross. And he had a really straightforward conversation with me and said, "That's great. You should follow your passions. How are you going to support yourself?" And I sort of looked at his house and I said, "What do you mean?" And he said, "Well, just until you become a famous motocross racer, why don't you get a job?" And he got me a job in one of the warehouses that he managed. And 3 days later, I said, "I'm going to college." And I went to college where I was recruited to play football. That's the only place I had applied to. So I went to Johns Hopkins in Baltimore, small uh, college, and played football and wrestled and had a fun time, and came back to my fraternity house one day, and my roommate was applying for teaching jobs. So I said, "What are you doing?" He said, "I'm applying for jobs." And I applied for a teaching job. So I was an elementary school teacher. And when I was an elementary school teacher, I went to a new teachers conference and I met my wife, who is currently a pediatric orthopedic surgeon. And at the time, I'd applied to medical school, law school, and graduate school because I was unsure of what to do. And I really went to medical school to impress my wife. And I went to medical school, liked a lot of things, didn't like some other things. And through a process of elimination, found myself doing emergency medicine. I did my residency and fellowship at Johns Hopkins. And through a series of trial and error, was able to run things. And it turns out that I like to run things. And the first thing I was asked to run was a helicopter program. And then I moved in 1998 to Boston and took a 1-year job at Brigham and Women's Hospital, thinking I was going to go back to to Hopkins and stayed there for 14 years. And over that period of 14 years, um, like to take different approaches to things that have been done for a long time. And that was anything from setting up urgent cares or multi-specialty clinics to how helicopters should or shouldn't be dispatched to thinking about emergency preparedness and disaster response. So it was really having a different approach to things that people have done for a long time. In 2012, I was recruited out to the University of Colorado School of Medicine to be the first chair of the Department of Emergency Medicine. And it was not a department before. And I had that same approach. And when you think about how chairs are recruited, you negotiate with the dean, you can negotiate with the CEO, you get a little startup package, and you create a business, you create a department. And looked across the country and talked to some mentors, and they said, well, you take the amount of money you negotiated for, you divide by 7 to 10 years, and you spend it over 7 to 10 years. And at the end of 7 to 10 years, you renegotiate and get another package. And I thought that sounds horrifying. And I spent every dollar that I was given to start a department in about 18 months. And started off, the first person I hired was a industrial engineer from Caterpillar Tractor. And we redesigned how emergency care is delivered. And that one emergency department went to 27 emergency departments, 25 urgent cares, a very large virtual health platform. And a lot of other places came to look at how we reorganized emergency care. 60 different systems, 4 different countries, was just in Japan talking about it. Over that course of starting an academic department, we found that deploying technology rationally could decrease the cost of care, improve quality. But I found myself not wanting to pay for this technology. So I'd never done this before, but we started working with companies, and I would co-develop with my department their technology, think about how to deploy it, and then create a revenue stream. And then 8 years ago, the CEO of our health system asked if I'd like to do that for the health system. And we created the Care Innovation Center at UCHealth. And the Care Innovation Center very specifically partners with industry to think about how to bring technology and novel solutions to healthcare. And we like to say that our best partners are ones where we are a customer, co-developer, and participate in value creation. And we start off with a problem statement. And the best problem statements are ones that come from the people doing the work, the front lines. We codify that problem statement in an exquisite, very deliberate way, one page formatted. Then we do an environmental scan of how we're going to solve that problem. And the environmental scan usually is talking to other health systems. And if they've solved it, we don't have to reinvent the wheel, and we don't have to do anything but learn and adopt and implement. But if they haven't solved it, it's pretty clear that it's a problem statement that's not just germane for me and our health system, but for all the health systems in the United States. And then we'll look at companies from 3 people in a garage in Palo Alto to a Fortune 50 company to see if they have a solution. And very often we'll find technology partners that have a similar solution in a different industry, or companies that have worked in healthcare that have always wanted to do this. And we'll pick a partner, and then we'll think about how we solve a small problem, and then think about how we solve this big problem and how we scale. And that's really my job, and that's what I do.
That's exciting. Uh, and I've always heard of UC Health doing this kind of work over the years, just kind of in the circles that I run in, and it was one of the reasons I was more excited to connect with you when we did. Um, and I think we've seen more of it, like more health systems kind of doing this type of work in the last 5 years. I would say, like trying to create kind of more innovation arms. A question, as you were talking about the work that you did with uh, the helicopter program, and then getting to um, UC Health, and creating this new program. In a number of the last few positions that you've been in, you've been bringing a lot of change to the organizations. Good change. what are some of the biggest obstacles that you've run into in trying to implement change, and how did you kind of navigate that? Because a lot of the times when I see health systems encountering difficulties in innovating, it's because of either some political stuff here or enrollment there. How did you become an expert in that kind of work?
Can't say I'm an expert in this kind of work. I can say that um, we like change and we don't fear failure. So
William.
it starts off with the problem, right? So I'm not instituting a technology that people don't feel is going to help them do their job. So the guiding principles are really straightforward. They are abhor bureaucracy, fear inaction, not failure, and create solutions that benefit people, right? It's pretty straightforward. So when we see a problem statement that comes from the front line, we by definition have a subject matter expert and early adopter because they're the ones that have brought the problem forward and it's their job to deliver that care or that process, whatever it is. So we think about that person and what they are expert in, which is not technology, which is not finance, which is not unless it's a finance solution. And we ensconce them in resources and we create self-fulfilling prophecies. What we ask our subject matter experts to do when we bring a solution, a potential solution or potential partner, is I say to them, I don't want you to like the company or the solution because I like it. I want you to listen to them. And if what they propose is true, will it make your job better and our patients' lives better? Full stop. And if the answer to that is yes, then we'll start. If the answer to that is no, there's nothing to do here, nothing to see here. So if the answer to that is yes, we'll do a technological deep dive. We'll do a financial deep dive and we'll do what the ROI is, meaning an ROI for us is not just dollars. It's how many people don't die and how many people's lives are better. And when we do that, then we'll go forward and we don't do pilots. So we don't have pilotitis. We do phased deployments. So we'll start in one place, then we'll go to 2, then 4, then 8, and then 16. And we iterate as we go. So there's no chance that everything is going to work when you deploy it. And we categorize deployments, um, whether it's customer facing, patient facing, or administrative automation. So we do different things in those 3 verticals. And then we iterate constantly and we think, does this require a break fix? Is something broken? We have to fix it. Or is it iteration? And we tell people ahead of time that if something's broken, we're going to fix it. But if something needs to be iterated, we're going to let the process breathe and learn, and then we are going to iterate. So whether it's 3 weeks or 3 months, we're going to let it breathe and learn, and then we will change it. So we don't change things minute to minute that don't need to be changed. But we do iterate, and we've developed some confidence with our end users that we actually will iterate. So if something doesn't feel right, doesn't look right, they know that we're going to make it look right and feel right, but just not immediately. So if we think about clinical decision support or bringing intelligence into workflows, again, guiding principles has to be easier, not harder, fewer clicks, not more clicks, path of least resistance, and bulletproof writing. And that's it.
Yeah. Um, Super cool. I mean, you mentioned fear. I mean, or what I heard and what my experience has been is that a culture of fear in an organization, be it in healthcare or outside of healthcare, is one of the biggest enemies to innovation, right? Nothing can create more inaction and trepidation than, you know, an organization that's had a leader that's been, we need to get everything done yesterday, and like everything's always on fire and people are always in a reactive posture. And it creates this they're not sure, what's going to happen or how dad's going to come home and what he's going to say. And like, we've encountered a lot of that. It's very hard to innovate in that type of environment. So the point of all that is it sounds like not only have you enrolled the front line in this kind of like, hey, tell us, what these use cases are, tell us what the problems are. Um, but it sounds like you have some good support from an executive, standpoint. I mean, you said straight up, I think the first thing you said was we embrace change or we like change, right? Which I think it's cool to lead with a statement like that, because so often like people are just so fearful of change in general.
Well, change is hard, right? Change lives in your amygdala, right? It's an emotional thing. And if change is too dramatic, is unnavigatable, then everybody regresses to what they know because it's so emotional. So we try and sort of make the change small, but also help people understand why we're doing this. And also pick winners, right? Create self-fulfilling prophecies. Pick the people who want to change, show what right looks like, and then everybody else wants to be like them. So we're not saying to everybody, you got to change now, but we're saying, look, here's the problem statement. Um, our patients are relying on us to do things better, faster, more efficiently, safer, in a lower friction environment. And look, Sally or Timmy just showed what right looks like. Now everybody wants to be like Sally or Timmy, and we're going to help them get like Sally or Timmy. It, I also tell people that if you have 9, 15, 12 goals, whatever they are for your year, and you've hit every single one of them, then you weren't trying hard enough
Mm.
because you were not aggressive enough in what your goals are. Because you cannot get 19 out of 19 or 11 out of 11, right? There's maybe you hit three or four of them, stumble or three or four of them, and three or four of them are abject failures because you will learn as much from a failure as you do from a success. Now, don't repeat the failures. I did okay in school, but I learned as much from my D's as I did from my A's.
Yeah, and I want to double click on that, but before I lose the other train of thought, um, I presented in Cambridge a month or two ago to a bunch of NHS executives, and McKinsey came in, and we were talking about um, how the adoption of ambient listening technology in a clinical setting has been one of the most significant uh, adoption or like innovation curves in recent history of healthcare, right? Like that just, in so much as it's an AI based solution. And I think that you nailed it when you were talking about like, when I think of ambient listening, it's a pretty straightforward use case. Like you're talking to a patient, this technology listens and then transcribes and then summarizes, right? It's very easy to get my arms around it, even if I'm not a technical person. Um, and it can dramatically enhance the experience of the physician. And so like it kind of checked all those boxes, and it just started to make more sense why it was such a success. Because then you had one doc use it, they were excited about it on the front lines, and then it just kind of spread like wildfire, right? Uh,
Yeah, and I think that's just the beginning. If you think about general purpose technologies and the deployment of ChatGTP versus the smartphone versus the internet versus whatever, um, the great thing about ambient listening or AI is you don't need a new device. You turn it on. It's relatively frictionless, relatively, and it almost seems spooky in the way that it works. And at the end of the day, you don't have to spend 2.5 hours doing your charts when you're seeing patients. And the charts are better, and the patient experience is better. The physician experience is better. So that was a perfect storm where the technology um, found the right problem statement, or the right problem statement had the technology. But if you talk to the CEO of a bridge, that dude's been working his butt off for years on this. It wasn't an overnight success, right? There are not, you know, overnight billionaires. They're people who've worked for years on this problem statement, almost maniacal on the way they've solved this. And now it looks easy, but you have to work pretty hard to make something look easy.
right. Yeah, and I didn't mean to discount that. As an entrepreneur, I know that well. Um, I did want to double back, Richard. So personally, I have learned more from my failures and my successes, significantly more. In fact, I'd argue that some of the most transformational moments in my life have been per the result of actually very dark moments in my life. Not always, but you know, some of the moments in particular, I was in the muck, but then coming out of it, I ultimately took away some profound lessons and perspective shifts. So my question to you is there a time that sticks out in your over the course of your entire career that you had a moment like that, or a time, you had one of these projects that didn't go well, but you ultimately took away a useful lesson? Um, I usually get a lot out of these dialogues.
I think I've had, I was going to say dozens, but probably hundreds of sort of welcome to the NFL moments, right? Where you get on the field, you know you're going to get hit, but you can't possibly imagine how hard you just got hit. And that's a welcome to the NFL moment. And you can substitute any sports analogy or music or performance analogy for that. I think the the biggest welcome to the NFL moment I've ever had was when I left my job in Boston, came to Colorado, and new guy started a new thing, new leader, and I knew exactly what to do. At least I thought I knew exactly what to do. What I didn't understand was how I was supposed to communicate that, and how I wasn't supposed to do everything on the same initiative on the first day. And that was a life lesson in communicating the vision is just as important as thinking about what the next steps are. And just knowing what to do is not enough. It's knowing when to do it and how to do it. And also realizing that different people have different processes for understanding what is expected of them.
Yeah,
So, and that was my lesson in change was that, most physicians are introverts, not extroverts. Most physicians are pretty autonomous in their thinking because we've trained people to be autonomous and independent because it takes a lot of gumption to say you should have this medicine or that, or I'm going to operate on this part of your body. So understanding that mindset was a welcome to the NFL moment for me. And then essentially delivering and over delivering. You can't emphasize that it's all about execution. So compassion without competence is crap. That's my 3 C's of innovation, right? You have to focus on execution, and then you have to focus on execution, and then you have to deliver, and then focus more on execution. Think about workflows, think about how people process, think about the impact of their daily life. And the technology had better work, but you better pay attention to the other stuff first.
right. Yeah, meet people where they're at. That's another big thing I've taken away from lessons like the one you're mentioning. Um,
Another big lesson for me was, and this is hard, right? This is really hard for someone who's not in technology, who is not in venture capital, who's not in private equity, who started off in academic medicine or eventually in academic medicine, is I saw some badass technology that I thought would be revolutionary. And the team was pretty mediocre and inexperienced. And everybody always says, bet on the jockey, not on the horse, but I didn't know what the hell they were talking about. And then I learned it the hard way, which was if you don't have a team that can execute and understands change management and process, doesn't matter how good the technology is, it's going to fail. And I had some really remarkable failures where I thought the technology was badass, and I still think it's badass, but it's dead.
yeah, I mean, we've even seen some situations where organizations have made people believe that the technology is badass through really badass marketing and advertising. And not only is the delivery, touch and go, but the technology itself, actually, when you look under the hood, isn't so badass. It's average at best. So definitely in a at a time where there's more noise than ever about AI and technology solution providers. I mean, I think you started the episode, like I said, so profoundly, like with starting with the problem in mind. And then past that, you've also kind of, or what I heard throughout the episode too was like, we don't have to reinvent the wheel if other people have gone through this, right? So how can I leverage the experiences of people in my community that may have walked through something similar, and and leverage that, right? So that we don't have to do the same thing. So for example, if somebody's used that vendor and the delivery was none too successful, and then you hear another that was not too successful, it's not the one reference they gave that was good. um it's important conversations to have.
Yep. We, I'll just continue on my welcome to the NFL moments. We are a relatively innovative health system. Um, 14 hospitals. We're pretty new. We've only been in existence for 13 years. So we don't have that attitude of this is the way we've always done it kind of a thing. Um, but another, you know, learning was that I can't create a solution that only works at UCHealth. So if I have a solution to a problem and it works here, but I have lots of informaticists and remarkable programmers and analysts and pretty innovative and adoptive environment, if it doesn't work at Our Lady of Faint Hope, or if it doesn't work at another health system and it's not scalable, it's not going to last. So there's no use in doing that. So we're very used to being a beta customer and a co-developer, but we design solutions for customer number two, not customer number one. So design solutions for customer number 2 through 2000, and we have to help that company scale. Because if that company can't scale, that solution that we've become so attached to disappears.
After you said that, my mind went to, you know, some of the health systems that we know that have been innovating in access using like AWS Connect, for example, and who have been building and tinkering and may have the development chops to do that. And so I don't know where I was going with that. I just,
So some of the companies, when we think we have a solution that works, I will get on the phone and I will call my colleagues across the country and say, you should look at this company. And then when they go out there, I will send my own people out there to help them implement, because it's in my best interest, not just from an investor perspective, but it's in my best interest from a deployer of technology and a user, that that company be successful. Because if they aren't successful, they can't continue to iterate and grow. And then I lose that solution.
right. No, that makes sense. It's very interesting. Um, well, I want to talk a little bit more about the work you guys are up to at UCL. That we've kind of started to get into it already. Richard, before I do, I always just like to ask, favorite book or literary piece, either that you've read recently or all time. Your choice.
I just reread The Sun Also Rises. I just went on a trip to Japan, and I just pick a book. I always pick a book that's not too long, not too short, that I've read before, um, because I know that how it ends, and I know that if I can't get through it because the flight ends or whatever, that I know how it ends. So I reread The Sun Also Rises, and I probably have read that book a dozen times, and it never disappoints.
Do you find that you always like have a new experience with it? Like you take something new away from it, or what compels you to reread a book over 10 times?
Well, this is very specific to Hemingway, and Hemingway has a remarkable, unique, simple prose that is so complicated, it's simple, right?
Mm.
As Mark Twain said, if I had more time, I'd write a shorter story or a shorter book. Um,
Right.
it Hemingway I find to be the same way. So it speaks to me in the context of where I am in the moment. Even though I read it 7 years ago, I'm a different person now, and I feel it's a different book now. Not a lot of authors can do that, but Hemingway does that for me.
I love that. Super interesting. Uh, Glad I asked that. Uh, so Richard, how long have you been at UC Health now? I mean, you told us before,
13 years.
13 years. So you're in this role, chief medical officer and innovation officer. Obviously, kind of dual responsibilities there. Talk to me a little bit more. I mean, we've heard a little bit about your vision based on the overarching mission of the organization, but maybe some of the key initiatives you're working on, or some of the things that you're most excited about, perhaps some of the problems that have been brought to you recently that you could share, um, about the way that you're approaching those, things like that.
So when we think about innovation for us, right? Innovation is a term that means everything and nothing. We think about intelligence, another term that means everything and nothing. So for us, we say that our innovation strategy is our IT strategy, is our quality strategy, is our virtual health strategy. And when I say we focus on intelligence, I say we focus on making better decisions in healthcare. And that could be a physician at the bedside choosing a drug. It could be an administrator thinking about how to better organize operating rooms. It could be a chief financial officer thinking about how to automate rev cycle. It's really about making better decisions. So, where can I instill intelligence in the process of delivering healthcare or administrating healthcare, where I can make it faster, better, easier, safer, more efficient, decrease cost, increase quality? So, that's how we start. And I'll give you an example about incidental findings. So when you get a chest x-ray for any reason, let's say you see me in the emergency department and I get a chest x-ray because I'm worried about pneumonia, and you don't have pneumonia, but you happen to have a little bleb somewhere on your chest x-ray, that's an incidental finding. That incidental finding could be nothing, or it could be a cancer that could be cured if I figure it out. Those incidental findings are very difficult to keep track of. They're extremely difficult to keep track of. Now, look at chest x-rays, look at CAT scans, look at pap smears, look at mammography, look at thyroid scans, look at EKGs, look at all of those things. All of these tests are done for a specific purpose. Sometimes that purpose is binary, yes or no, but sometimes the purpose is you don't have the thing I was looking for, but you got this other thing, and we don't know what it is. Let's keep an eye on it. The we don't know what it is. Let's keep an eye on it is very complicated problem when you multiply it times 8 million patients or 30 million patients. So we partnered with a company, Eon Health, and then in full disclosure, we're an investor in that company that thinks about how to track incidental findings. And they use computational linguistics along with care managers to follow patients with these incidental findings so that we know that if you have a chest x-ray with a nodule, we'll have AI look at the nodule, we'll have a human look at the nodule, and we'll say, nothing to see here, or you need another chest x-ray in 5 years, or you need a CT scan in 3. And we will keep track of every single incidental finding in every single patient throughout that journey. And we'll do it with low friction because we're using technology to do that. And when we keep adding new modules, so we started off with pulmonary nodules, and then we added thyroid scans, and we added pancreas, and we added a whole bunch of different modules. The number of cancers that we are preventing and treating early is in the many, many thousands. So that's a pretty pragmatic problem with, I think, a pretty interesting solution. And that's one of the examples. Another example is a company, also full disclosure, we invested in called Arrive Health. And Arrive Health is now in the native Epic and Cerner. So if you turn it on, it's everywhere. But it does pretty straightforward stuff, which is when I write a prescription for you, it electronically tells me as the provider whether your benefit manager, your insurance covers that prescription. If I write you a prescription that in your coverage has a copay of $1,000 a month and you can't afford $1,000 a month, that's a useless thing for me to have done. So we went from having a third of the prescriptions, which is pretty common, not picked up, to almost no prescriptions not picked up because of copay issues. So I can say to you, hey, this medicine is $100 a month, but there's another medicine that's just as good, maybe not as convenient, that your insurance covers, that's zero. Which one would you like me to prescribe for you? And everybody has different situation. Now multiply that for other things, like not just real-time benefit check, which this is, but electronic prior authorization as well. So that instead of waiting for 3 weeks and having 14 people call and faxes, I mean, imagine that, we're still using faxes, before you can get your infusion or your medication, it now does it electronically. And it doesn't do it instantaneously, but it does it way faster with less humans and higher accuracy. So now that company started with us, and now it's in 60% of the systems in the United States, millions and millions of patients. Uh, that's a big win because it could scale. The same thing with Eon Health, it can scale. If it just stayed with us, it would not have evolved.
Just like so impressed with like companies like that come in and solve a problem and that scale well. It's exciting.
But the point is that for every company that does that, we've looked at 100 others, right? So I think in the last 3 years, we've looked at 700 companies, and we've picked 17 companies to co-invest, co-develop with in the last, 6 years. So that's 17 out of 1,000.
Oh, I know one of the things that I was going to ask because I did a year or two ago. We did a imaging latency assessment for a large academic health system, we'll just say on the East Coast. Um, they thought they had a few PACS systems. It turns out they had like 7 or 8 different PACS and CPACS systems throughout the health system. Um, how does Eon like handle a situation like that when you have like multiple different systems?
Using computational linguistics, it can look at unstructured data and, sort of like natural language processing. So it doesn't matter where the report is. It can be in a PDF, it can be in a Word document, it can be in the EHR. It recognizes chest X-ray, nodule, and then it goes into a process.
Wow, super cool. I'll have to talk to you more offline about that. But what about some of the biggest challenges, Richard, that you guys are facing? We've talked about a lot of the exciting stuff that you guys are doing, but I know even when we first met, we were kind of talking about the state of the union, so to speak. What are some of the biggest challenges that UC Health is facing right now?
So the biggest challenges that UCHealth is facing are the same ones that many other health systems are facing. The financial environment is degrading. Uh, the regulatory environment is becoming paralyzingly burdensome, especially in Colorado. We went from wherever we were 10 years ago. Now we're the sixth most regulated state in the country. And the legislature is promulgating an AI bill, which, if enacted in its current state, would essentially make electronic health records not legal. So that hopefully won't happen in the way it's written. But between the financial pressures and headwinds and the regulatory burden, those are the big things that are crushing healthcare right now. And from an AI deployment perspective, despite I think the potential for AI in healthcare is infinity. I'm more excited than I have ever been about anything else. But the financial pressures and regulatory burden are the biggest thing that will limit AI. AI, I think, is just math, right? It's not magic. And you require human adjudication in medicine. You'll always require human adjudication. No one should be scared of AI, but we will regulate it out of existence if we're not careful in healthcare.
Right. And uh it's always been challenging to me when I think about, you know, issues like the like governmental regulation or the multi-payer provider system in general, or like things that I really can't affect change on. Like how do you deal with that with those like kind of macro concerns? Like is it just it's just something that we have to hope sorts itself out, or is there anything else you would suggest to like other executives that are in the exact same position as you? And I'm just curious based on my own ignorance and not sitting in that chair. It affects what we do as, advisors and consultants, but not nearly as much as someone like yourself, obviously.
Yeah, I mean, part of it is the pragmatism, right? If everything's a crisis, nothing is a crisis. You have to pick what it
Mhm.
is you're going to do, and then you have to keep doing your day job, which is seeing patients and treating illness. I think if you look at new technology and include science and pharmaceuticals in that, the regulatory bodies have always been a little bit behind because they can't keep up. So the FDA has to be changed, and hopefully it is being changed. The NIH has to change, and hopefully it is being changed. The payer environment has to change. A great example is nothing to do with the work I do, but now you can cure sickle cell disease, or you can cure sickle cell disease, and it costs a lot of money to cure it. Whose responsibility is it to cure it? Is it the insurance company that's taking care of you now? Is it the public environment? Um, most people stay with an insurance company for 2 to 5 years, maybe even less than 5 years. So, are they supposed to treat something that is a rest of your life solution, or
Mm,
are they supposed to treat something that you have now? And sickle cell disease is something that's curative. It's remarkable that I'm saying that, but it's true. And whose responsibility is it to pay for that? And it did cost a lot of money to develop that technology and that therapy. So it's reasonable that it's expensive. But whose responsibility is it? Whose responsibility is it to um, make sure you don't get kidney disease when you're not going to get it in the next 3 years? You're going to get it in 12 years,
yeah,
right? Do we have to do it just because we can, even though it could be impossible to finance? So those types of solutions don't have an immediate answer. No one did anything wrong because we don't have a solution. But we have to get together and think of generational solutions, which we seem not to do anymore.
right.
You're not going to build the
Yeah,
Hoover Dam for next week. You're going to build the Hoover Dam for the next generation. So we have to think about generational solutions to problems, which we seem not to have the gumption to do anymore.
yeah, that's so true. Um, so Richard, a couple last questions here. I mean, you just got my wheels turning, which I love. I mean, I love conversations like this. So what are some of the, as we move forward, I mean, you mentioned some of these companies that you're, working with already. Is there any other solutions that you're particularly excited about that are on the horizon that you think are going to serve to propel us forward into this kind of next uh, era of healthcare delivery? Anything else you could share with us?
I think that the current potential, last week, I just went to the NVIDIA conference and was pretty blown away by what's going to happen in the next decade. I'm convinced that my grandchildren are never going to have to learn how to drive a car, and that
Mm.
before I die, I'm going to have a robot assistant in my house. So there's that. Um, I think the combination of what we're doing with AI and data science will fundamentally change the way in which healthcare is delivered. And if we are judicious about how we use humans and judicious about how we deploy AI, there are disease states that will not have to exist anymore. There's countless years of suffering that humans will not have to endure anymore because the first time you see a provider, they will make the impossible diagnosis because it took 17,000 variables to be adjudicated at the same time. So it won't take 5 years to make the diagnosis. It'll take 5 minutes or, 5 hours. So that is beyond exciting to me. The fact that I don't have to memorize things anymore and I can look into people's eyes and figure out what it is they need from me this day. And I can let a computer adjudicate, 1,000 variables where I'm a reasonably smart guy and I can do 8, 11 on my best day, right? That's pretty exciting.
Yeah, it really is. I mean, as challenging as these times are, I mean, based on what you mentioned, I am incredibly optimistic. So, yeah, Richard, this has been great. Thank you so much for taking the time today. I like to end with a question. If you could go back 5, 10, 15, or even 20 years in time, what advice would you give your younger self?
Be in the moment.
Hmm, love that. Richard, thank you so much, man. Appreciate your time today.
My pleasure. Thanks for having me.
To our listeners, thank you for tuning in, and we will catch you all next week.